Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. It's 3 a.m. Elena is a nurse in a busy ward. She's 6 months into her first year of work, the exact time when research says she's most likely to consider quitting. Elena is at the bedside of a patient who is scared and has questions about their plan to go home tomorrow. But her phone is buzzing, another patient's monitor is alarming, and she still has 2 hours of charting to catch up on. She knows exactly what her patient needs: a few minutes of human connection. But the system around her makes it physically impossible to provide it. This feeling has a name: moral distress. It's the pain of knowing the right thing to do while being blocked by organizational constraints. When that happens, shift after shift, it leads to burnout, that physical and emotional exhaustion that makes even the most passionate nurses want to walk away. On today's episode of Mapping Healthcare, we're talking about something that is the heartbeat of healthcare, but often feels like it's on life support itself: the clinical work environment for nurses. Elena isn't alone. Right now, about 40% of registered nurses report plans to leave the profession in the next 5 years, citing stress, workload, and understaffing. Globally, we're looking at a deficit of 4.5 million nurses by 2030. So how did we get here? And more importantly, how do we handle this? If we look back at the history of improving clinical environments, the journey really gained steam in the United States in the 1980s, with the concept of the magnet hospital. These were specific hospitals that acted like magnets because they could attract and retain nurses even during a shortage. They focused on things like high job satisfaction and better patient outcomes. Over time, researchers developed tools like the Practice Environment Scale to actually measure the health of a workplace. It looks at 5 areas: staffing, leadership support, nurse-physician relationships, participation in hospital affairs, and the quality of care delivered. It's a vision for what's been called a moral milieu, a culture built on mutual caring, kindness, and transparency where nurses can flourish. Our guest in today's episode of Mapping Healthcare is Professor Sabelile Tenza, who is an associate professor of patient safety and healthcare quality at Northwest University in South Africa. She is a public health specialist at Northwest University's School of Nursing Science and president of the Accelerate Patient Safety and Quality Care Network in South Africa. She and her team looked at the clinical practice environment of nurses in public hospitals across South Africa and its relationship with patient care. The views expressed on the show are mine and those of my guest. So, Sabelile, welcome to Mapping Healthcare. You worked on research that surveyed over 1,300 nurses in public hospitals across all 9 provinces of South Africa to look at the relationship between their clinical practice environments and the quality and safety of healthcare. Can you paint a picture for our listeners of what that environment looks like day to day for a typical frontline nurse in the setting, so we understand how these circumstances could affect patient care and outcomes?
Thank you very much for that question. So let me just start by just giving a brief background of South Africa. So in South Africa, the population as of 2025 is around 63 million. And we have the access to healthcare, it is really unequal, with about 70% of population receiving public health services funded by the state, and the other percentage funded by the private sector. So the public health sector is more overcrowded and having delayed waiting times of an average of about 3 hours in a primary health care facility. And the doctor-patient ratio is about 1:3,000, and the nurse-patient ratio about 1:2 over 200 patients. So this affects teamwork and it affects staff morale. It also affects productivity and leading to absenteeism. And you get to a point whereby those who are present on duty are bearing the brunt of being on duty or of being loyal, because then the absent people make them to have, it makes it more difficult for them to handle the duties. And this leads to the frontline people then to have difficulties in the workload, and also the frontline leader turnover become very high, such that you find that the frontline leaders in most hospitals, they are people who are on acting basis. They are not permanently employed because of the high staff turnover and the leader turnover. So they are actually in acting position than being in their permanent position. All this then, it creates that nurse practice environment that is not so conducive for good patient outcomes.
Yeah, so looks like, it's a difficult environment that nurses work in. And I'm thinking back to some of the environments that I've worked in various settings in the United States. And, it isn't quite different from those in terms of the time waiting that patients face, the level of acuity, the volume of work, and then the subsequent stress and potential burnout. So really hard, challenging environments that we place this precious healthcare resource in. And you found a significant disparity where nurses in central hospitals rated their practice environments higher, while nurses at smaller district hospitals had the most negative perception of their environment. So why do you think these smaller rural hospitals are struggling so much more than the larger institutions? And tell us about some of the dangers of this gap in your mind.
So, let me give you a background. In our South African context, a typical journey of a patient from home feeling sick and accessing healthcare services. So the first port of entry to the health system is a primary healthcare facility. So these primary healthcare facilities are within a cluster of hospitals, which is a combination of the small hospitals and the larger hospitals. And then it is expected that from a primary healthcare facility, if there is a need for referral, for escalation of care, then the patient will move from the primary healthcare facility, move to the smaller hospital, and then to larger hospitals, which are also teaching hospitals. So in that context that I've just given you, it then leads to, when there is allocation of resources by the Department of Health, it is then important that the resources, the financial resources, they are assigned according to the level of care and according to the demand of the services, which then lead to larger funds or larger resources to be placed in the teaching hospitals, which are also the more specialized. They have more specialists, they have lots of training happening, and they have more resource prioritization. And then the rural hospitals are not getting more of these resources, or the small hospitals, which are mostly located closer to the primary healthcare facilities. So what happens is that, for example, recent findings by the Ombudsman for Health, they found that in one of the smaller hospitals, no one was employed as a dietitian, and the food that was provided there was so compromised in terms of nutrients and everything. And you can see that is because then the absence of dietitian is a major contributor to that. And when I'm saying that, I'm giving you an example of the implications for these lack of small resources in these smaller hospitals. And one of the dangers is that then there is mostly compromised clinical decision making, because if then there is low resource location, mostly junior doctors or not so experienced people may also be allocated in these facilities in smaller hospitals, or even in the primary healthcare facilities. You'll find that there is no doctor in a day in the primary healthcare facilities. And that then leads to compromised clinical decision, and which then affect patient care.
The difference in care delivery and the challenges at the rural hospital level and the larger teaching hospital or urban setting that finding's replicated again and again wherever you go in the world, right? So that, I think, that disparity is a difficult one to tackle, and people all over the world are dealing with it. And one of your central takeaways from your work is the strong correlation between challenging nurse practice environments and poorer patient outcomes. It was also striking to me that more than half of the nurses in the survey that your team conducted lacked confidence in their patients' ability to manage their own care after discharge. And this suggests that a poor practice environment inside the hospital can have a ripple effect that jeopardizes patient health even after they leave the hospital setting. So while resource shortages are a major issue, your research also points to the role of management in hospitals. So how can nurse managers, nurse leaders create a positive environment and support their staff even when they're facing financial or material constraints?
Yes, thank you so much for that question. So, there are two things that I found them very important. Nursing managers, they need to prioritize empowering their teams and protecting their teams. I will give you some examples of what happens in the country, generally in most of the frontline leadership in the healthcare. You find that there is an ongoing culture that sometimes managers are placed in roles that they have not been trained for, and they are not well equipped for those roles. And sometimes you find that there is an ongoing culture of covering up issues. Maybe people, they are comfortable on not telling the truth. Say there is an audit, they would rather pretend that things are fine than unveiling the real truth. So those kind of things, they lead to more problems, because then if the problem is not unveiled, then nobody can be able to deal with it. So I would say they must be given powers to ensure that they get their duties right. They make correct decisions to choose who they employ and who become part of their teams. And in one of my studies, we found that there is poor delegation of powers to frontline managers. For example, if we were to ask any typical frontline healthcare manager on a problem, they would tell you there is no budget, because they have no powers to increase budget for themselves. So I would suggest there is an empowerment of frontline managers with leadership skills, advocacy skills. They must be able to speak up for the problems that they identify and provide solutions. And there must be opportunities for career advancement within the hospital, so that people can be able to progress and learn and not overstay their position, so that they can be able to work better in the positions they are still interested in working in. And they must not hide evidence of lack of malfunctioning resources, or if they lack anything, they must just say that in this hospital we don't have 1, 2, and 3, because if they do that, then the top management is able to prioritize such limitation of resources in maybe in the next budget, and be able to get that covered. I think that is very important for improving the positive practice environment.
Yeah, so having that direct connection to people that hold the purse strings of the financial powers in an institution, I think, helps nurse managers advocate for their team. And your data also highlights a concerning statistic. Over 64% of nurses felt that their mistakes were held against them. And in addition to the study, you've also conducted research on the implementation of national guidelines for patient safety incident reporting. Incident reporting systems are systems whereby clinicians in hospitals can report to a centralized database in their hospital negative occurrences or adverse events that occur. So how does this punitive culture affect a nurse's willingness to report errors, and how does that silence ultimately threaten patient safety?
Yes, actually in our recent larger study, which involved not just the nurses, the doctors, pharmacists, all different healthcare provider categories, we found that it's not even only the nurses that are having the problem of reporting incidents and in-care punitive measures. Everybody is scared. The punitive culture is really still very strong in the country, in South Africa, and it has major implications on errors that get left unreported. I mean, you may have a hospital that reports that in the whole year they only have 4 incidences reported, and that is really impossible. So the implications of that is that unreported errors deprive teams from learning from the errors. As you know, that the most important reason for reporting errors is that we learn from the errors. So then the errors that get unreported, then they get repeated. And then this threatens the patient safety, because if we don't learn about the system, we don't learn about the processes, we don't learn about these errors, we can then not be able to do a root cause analysis to identify where the weaknesses are. And as a result, then the patients, they really suffer. Patient safety is compromised.
Yeah, and one of the issues with empowering nurses in hospitals is the challenges they face in basically, being involved in the higher levels of hospital affairs and having their voice heard there. And so you identified the participation of nurses in hospital affairs as one of the lowest rated areas that nurses rated in their practice environment. So why is it so important for nurses, who you describe in your paper as quote unquote street level bureaucrats? You use that term in the study. Why is it so important for nurses to have a voice in their hospital decision making process? And explain why you use that phrase.
The nurses are the backbone of the health system, and they count majority of the frontline healthcare providers, and they have all the details you need about what's going on well and not well in your facility. When frontline healthcare providers are excluded in the matters, in the hospital affairs, in decision making, it becomes very difficult to get anything done properly. And it gets difficult to implement any policy. In policy implementation, we talk about the top down, the bottom up approaches. And if the people at the top level, they are policymakers, they are designing policies, but they are not including the people from the ground who know everything, what is happening, what is feasible, what is implementable, then it is really going to strain the whole implementation process. Because if now, for example, you want to buy a particular item for the hospital and you want to buy an equipment, and if the supplier is not speaking to the frontline healthcare providers who are going to be the users of this particular equipment, and then perhaps they only engage with the supply management and the finance management and exclude the frontline user, what happens? The decisions on which brand and the quality of what needs to be bought, those decisions, they often favor what is cheap in the market instead of what is quality and what's going to last longer. So hence, I'm saying it is very important that we get the involvement of the frontline healthcare providers in the decision making. And we have seen the lack of involvement of frontline healthcare providers in decision making in lots of policies that are implemented in the country. For example, I once did a study on the implementation of the Ideal Clinic initiative in the country. The initiative was focused on grading of facilities according to whether it's a good performing facility, putting a star rating in facilities like in the hotel system. And in the preparation of that policy, because frontline nurses were not involved in the policy development, the criteria that was used to check out if a facility tick all these criteria is going to be a silver star or a gold star, then that criteria was so skewed. There wasn't much that the facilities could relate, because it was absolutely not feasible, because of the lack of engagement of the people in the front line.
And so that disconnect with the frontline clinical workers, I think, has this ripple effect on how the public perceives hospitals as well in many of these ratings and reviews that we have now that are accessible to the public. So South Africa has strong published frameworks, just like many other countries do. And some of your frameworks are the National Core Standards and the Ideal Facility Framework that regulators and policymakers use to assess healthcare facilities. So your study found a disconnect between government policies and the actual quality of care delivered on the ground. So you conclude your article with an urgent call to focus on improvements in smaller hospital settings. If you could implement one immediate change to improve the practice environment in these smaller district hospitals, what would it be?
I think for me, the most important thing is empowerment, because there is already shortage of staff and people are already burnt out. So the most important thing for me, I would devise a strategy to motivate those who are willing to work and they are on duty. Motivational strategies. Leaders must have motivational strategies. And then I would want them to be so empowered and rewarded for being interested in delivering the services. And most importantly, the leaders must stay away from the culture of covering up unacceptable practice or covering up weaknesses in the facilities, because that it creates or it contributes to weak systems that are ready to fall apart anytime, because nobody is talking about a problem. When that problem gets discovered, you find that it's got a long history. Everybody knew about it, yet nobody was talking about it. So I think what is more important, and which doesn't even need money, is that leaders change the culture in the organization. They use motivation to encourage teams, and they stay away from the practice of pretending things are okay when they are not.
Yeah, well said, Sabelile. A culture of quality is strongly related to patient outcomes, which at the end of the day, that's what we all strive for, is keeping people healthy. And you clearly brought up the role of leadership, empowering frontline nurses, and working on culture, despite constraints that may be financial or material in the environment. When we wrap up each episode of Mapping Healthcare, we talk a little bit about the setting our guest works or lives in. And you work in Potchefstroom, and it's colloquially known as Potch, and it's located in the northwest province of South Africa, about 75 miles southwest of Johannesburg. So tell us a little bit about some of the activities or experiences or places of food in this area that someone visiting Potch should check out.
Potch, it is a small town, but there are interesting areas. I'm a fan of shopping, so there is a mall called Moy River Mall. It's got very interesting shops if you are a fan of shopping. And there's an interesting spa, which is called Feather Hill Spa, for if you are a fan of going out for body massage. And my favorite spot is also a place called Mike's Kitchen. It's got a nice play area for the kids. That is where I like just stepping out to take my kids for play. It's a very interesting place as well.
Yeah, so a lot packed into Potch. Shops, spa, sounds like stuff I would enjoy. And so, Sabelile, thank you for being on Mapping Healthcare and sharing some of your important work that highlights the role of nurses in patient safety and healthcare quality. In your words, you said nurses are the backbone of our healthcare system, and I completely, totally agree with that perspective. And really appreciate you highlighting that and appreciate you being on Mapping Healthcare. So thank you so much, Sabelile, for your time.
Thank you so much. I really appreciate being invited to this podcast. I'm looking forward to listening to it. Thank you.
So that was Professor Sabelile Tenza telling us about her experience with improving the clinical practice environment for nurses in busy hospitals with limited resources. The biggest catalyst for change is authentic leadership. Leaders who don't just sit in offices. They're self-aware, they listen, and they model the self-care they want their staff to practice. When nurses feel like their leader is one of them, listening, inviting feedback, and advocating for their needs, physical and psychological well-being of staff improves across the board. We are seeing a shift in the past few years on how we handle nurse staffing. Staffing isn't just a number, it's a synergy. The most effective staffing happens when there's a perfect match between a nurse's specific competencies and a patient's specific needs. The right nurse for the right patient at the right time. We're seeing hybrid nursing models where experienced nurses who might be physically tired of the floor can work remotely via telenursing to handle admissions or documentation. This keeps their expertise in the building without burning them out, freeing up the bedside nurse to actually sit and talk to their patient. There's also a push for AI to automate the sometimes soul-crushing administrative tasks and documentation that currently take nurses away from the bedside. So as we wrap this episode up, here are some of my big takeaways. First, communication and collaboration. A healthy environment can't exist if nurses and physicians don't see themselves as part of a trusting team where people can speak up without fear of humiliation or punishment. An environment like this increases patient safety and improves job retention. Second, autonomy and decision-making. When nurses have a voice in hospital policies and clinical decisions, often called shared governance, burnout decreases. You aren't just a cog in the wheel. You're a professional with authority over your practice. And finally, meaningful recognition. It's not just about a Nurse of the Week flyer. Effective recognition is timely, specific, and personalized to a person's individual values. If you're a leader, take the time to know how your staff actually wants to be acknowledged. At the end of the day, we need to build clinical environments where nurses don't just survive their 12-hour shifts, but where they're empowered to thrive. Because when nurses flourish, we all do. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with the show on Instagram at Mapping Healthcare if you'd like to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts.